Welcome to the deep dive. Today we're tackling something really interesting, though often frustrating: hypertrophic and keloid scars.
Definitely. And we're focusing specifically on non-surgical treatments, particularly for individuals with what's often termed skin of color, so Fitzpatrick types 4V to 6.
Exactly. We've gathered quite a bit of material. There's a big review from PubMed Central on these non-surgical options in skin of color, another piece looking at future therapies.
From clinical, cosmetic, and investigational dermatology, yeah. And some practical guides from the American Academy of Dermatology and Medicine, too.
Right. So our goal here is really to, cut through the jargon and give you a clear picture of the current landscape for managing these scars without surgery, especially considering those specific skin types.
And it's important because these scars, hypertrophic and keloid, they're more than just skin deep for a lot of people. They're raised, firm, sometimes itchy or painful.
Yeah, they result from skin trauma. Could be anything from surgery and injury, even acne or a piercing.
And the underlying biology is, well, it's an overreaction, essentially. Too much collagen gets laid down. Plus, there's this persistent inflammation.
And the sources really highlight that people with darker skin tones are more prone to them.
They are. Yet, specific treatment guidelines tailored for this group, they're still kind of lagging behind.
It's a real challenge. And we should probably quickly clarify the difference. Again, hypertrophic scars stay within the wound boundary.
Right. While keloids, they can really spread out, grow much larger than the original injury site. It's quite distinct.
So yeah, it feels like the standard playbook for treating these just isn't quite complete for skin of color.
Right, there are gaps. And no single treatment works perfectly for everyone. It often comes down to a very personalized approach.
Okay, so let's dive into the treatments. Where do doctors usually start?
Well, the consensus points pretty strongly towards corticosteroids as a first-line therapy.
Okay, corticosteroids. Why are they preferred, especially thinking about skin of color?
A big part of the rationale is minimizing further trauma, since these skin types can be more reactive to injury.
You don't want the treatment itself causing another scar.
Exactly. So injections are minimally invasive compared to, say, surgery. It's about reducing that risk of recurrence or even a new scar forming right there.
Makes sense. Less disruption. And the common one used is triamcinolone acetonide, TAC.
Yes, TAC is the go-to. It's usually injected directly into the scar itself, intralesional injection.
How often is that done?
Typically, it's like every 3 to 6 weeks, maybe for 3 to 6 months, sometimes longer. The aim is to soften the scar, reduce its size, and help with symptoms like itching or pain.
And does it work? What does the research say?
It seems quite effective. That PubMed Central review mentioned a study comparing TAC to another drug, verapamil, in African patients.
Okay.
And TAC was better not just at reducing the scar height, but also at relieving the pain and itching faster and more completely.
Yeah.
So yeah, it's a mainstay for a reason.
That sounds promising. But treatments often have downsides. Were there side effects mentioned with TAC?
Yes, definitely. In that same study, some patients using TAC experienced hypopigmentation, so lightening of the skin right at the injection site,
Oh, okay.
and sometimes skin atrophy, a bit of thinning. But these were localized effects. The verapamil group actually had systemic side effects, which is, less ideal.
Right, localized is generally better than systemic.
And another study suggested TAC's effectiveness might be pretty similar across different Fitzpatrick skin types. So even with the potential for pigment changes.
It might still be a better choice than some other options in darker skin.
Potentially, yeah. Especially compared to drugs that might cause more widespread pigment problems. The main thing with TAC is being aware of that localized lightening risk.
Okay, so corticosteroids are fundamental, but there's that pigment risk to watch. What about other injectables? Bleomycin comes up.
Bleomycin is another option, yes. It's an anti-cancer drug, but it's used off-label for scars. It can be injected or delivered using things like a dermajet or even tattooing techniques.
And how does it stack up, particularly for skin of color?
Well, the review suggests it's relatively well-established compared to some methods for these scars and skin of color. There was a study in a Vietnamese population showing like over 70% complete flattening of keloids.
Wow, that's significant flattening.
It is, and good reduction in itching and pain, too.
But there's always a but, isn't there? Adverse effects.
Absolutely. Pain during injection is common, though usually temporary. More concerning, though rare, are things like ulceration or tissue necrosis.
Oof. Oh.
But the more frequent issue, especially relevant here, is hyperpigmentation, darkening of the skin. Some studies report really high rates, even up to like 75, 76%.
That's a major concern for skin of color.
Huge concern. Blistering can also happen, and scars can still recur. So because of that high risk of post-inflammatory hyperpigmentation.
Doctors need to be cautious using it in darker skin tones.
Exactly. The review authors advise caution, suggesting its effectiveness might be similar to TAC, but the pigment risk is potentially much higher. So it's a trade-off.
Another balancing act. Okay, then there's 5-fluorosil, 5-FU,
Yeah.
also an anti-tumor drug.
Yes, 5-FU is used similarly, often for smaller keloids. It works by slowing down those overactive fibroblast cells.
Scar-building cells.
Right, and reducing collagen production. It seems effective at shrinking keloids and easing itchiness.
Is it used alone?
It can be, but it seems even more effective when combined with TAC. That combination is actually pretty common.
I see.
But the review points out we need more research specifically on 5-FU monotherapy, just using it by itself in Fitzpatrick types 5e to 6. The data isn't quite there yet for its solo use in this group.
Got it. Holds promise, socially combined, but needs more solo data for skin of color. Okay, moving away from injections. Lasers. That's a huge area.
It is. Laser therapy uses light energy for skin resurfacing. Broadly, you have ablative lasers, which remove the top skin layer, and anoblative, which work deeper down without damaging the surface as much.
And for darker skin, the big worry with lasers is pigmentation changes, right? Post-inflammatory hyperpigmentation, or PIH.
That's the primary concern, yes. Heat from the laser can trigger excess melanin production. That's why fractional lasers are often preferred.
Fractional, meaning they only treat tiny dots of skin.
Exactly. They create microscopic treatment zones, leaving the surrounding skin untouched. This allows for faster healing and, crucially, lowers the risk of widespread pigment changes compared to fully ablative lasers.
That makes sense. Are they usually used alone for these scars?
Research on laser monotherapy is still a bit limited. You often see them used as part of a combination approach.
And what precautions help minimize that PIH risk?
Things like using sunscreen religiously before and after treatment. Sometimes hydroquinone, a lightening agent, is used cautiously.
Okay.
And during the laser procedure itself, the dermatologist might adjust settings like using fewer passes over the skin or employing cooling devices to keep the skin temperature down.
Right, fine-tuning is key. Now let's talk specific lasers. Non-ablative ones first, NDEG laser.
The NYAG laser, especially the 1064 nanometer wavelength, has shown good results for keloids across all skin types.
Why that specific wavelength?
Because it penetrates deeply, but it's less readily absorbed by melanin compared to shorter wavelengths.
So less risk of targeting the pigment itself.
Precisely. One study even showed significant reduction in scar volume and blood vessels compared to steroid injections, and importantly, no pigment abnormalities, no dyschromia were seen in the darker skin types treated.
Wow, no pigment changes. That sounds like a really good option then.
It does seem particularly suitable, yes. It's also shown effectiveness for scars that didn't respond well to steroids, though recurrence can still happen, so multiple sessions are usually needed.
Okay, NYAG looks promising. What about the pulse dye laser, PDL?
PDL uses shorter wavelengths, like 585 or 595 nanometers. It's quite good for reducing redness and improving texture and flexibility in hypertrophic scars.
But shorter wavelengths, more melanin absorption.
Potentially, yes.
Yeah.
That's why the sources emphasize using low energy settings or fluents and good cooling techniques when treating skin of color with PDL.
So careful technique is vital.
Absolutely. Lower energy, treating early, multiple sessions, these might improve outcomes, especially in very dark skin, type CS. But the risk of pigment changes is definitely there because both melanin and the hemoglobin in blood vessels absorb these wavelengths.
Tricky. Okay, those are non-ablative. What about the ablative side? Fractional CO2.
Fractional CO2 lasers have been studied. Remember, fractional is key here for safety in darker skin. One study showed significant improvement, especially in scar pliability, in a mixed group including darker skin types with minimal pigment issues reported.
Did they adjust the treatment?
Yes, they actually used wider spacing between the laser spots for the darker skin participants, again highlighting that need for personalization. Early treatment with fractional CO2 might also help with scar height and pigmentation.
And the erbium lasers, UGA or Glass.
Erbium lasers are generally considered a bit gentler than CO2. Glass showed improvements in scar texture, pliability, and pigmentation in types 2 to 4s, with no PIH reported in the type IV patient in that particular study.
That's it.
And AG successfully reduced scar height in types IV and V with minimal side effects. The general feeling seems to be that while fractional CO2 is powerful, AG might carry a lower risk of PIH in skin of color.
So maybe a slightly safer bet for darker skin, but CO2 might be preferred overall.
It's sort of shaping up that way, but we definitely need more head-to-head comparison studies to be sure.
Right. It's clear the lasers offer options but require real expertise, especially with skin of color. Now, you mentioned combination treatment several times. Why is combining therapies so important?
Well, like we said, these scars are complex. They involve collagen, inflammation, blood vessels. Multiple things are going wrong.
So one treatment might only hit one target.
Exactly. Monotherapy might not be enough. By combining treatments that work differently, maybe an injection to reduce inflammation and a laser to remodel collagen, you can potentially get a better overall result. The sequence and timing matter too.
Makes sense. What about simpler, non-invasive things used as add-ons? Silicone sheets, pressure garments.
Yeah, those are very common. Silicone gel sheeting is thought to work by hydrating the top layer of skin, the stratum corneum. This might kind of calm down the inflammatory signals.
Okay. And pressure.
Pressure garments apply mechanical force. The idea is this might trigger cell death, apoptosis in those overreactive fibroblasts, or maybe just reduce their blood supply through compression.
Do they work well together?
One study in a Chinese population found that using both silicone sheets and pressure therapy together was better than either one alone at reducing scar thickness after 2 months.
Interesting.
But by 6 months, the combination wasn't significantly better than pressure alone in that study, so it's a bit mixed. And again, more research specifically in diverse skin of color populations is needed.
Always more research needed. What about combining lasers with injections?
That's a very active area. You might use a laser, almost like a surgical tool, to remove a keloid, especially something like an earlobe keloid, and then immediately inject tack into the base to try and prevent it from coming back. That's shown success in darker skin types.
Or using them sequentially.
Right. Maybe use PDL first to target the redness in blood vessels, then follow up with tack injections to shrink the scar volume. Often requires multiple sessions, maybe 4 to 6, for the best outcome.
And then there was that other technique, laser-assisted drug delivery, LADD.
Yes, LADD. It's
Yeah.
pretty clever. You use a laser, often a fractional ablative one like CO2 or erbium, to create tiny channels through the outer skin layer.
Like poking tiny holes?
Essentially, yes. This allows topical medications, which normally struggle to get through the skin barrier, to penetrate much deeper and more effectively.
And corticosteroids are often used this way.
Very often. Studies in pediatric burn patients, including those with all Fitzpatrick skin types, showed significant scar improvement using LADD with topical tack, and importantly, without causing pigmentation problems.
That's great, especially for kids.
Yeah. Sometimes they even combine lasers, like using PDL first, maybe adjusting the energy based on skin type, then the fractional CO2 for the LADD channels, followed by the topical steroid. Case studies also support LADD with steroids for keloids in very dark, type VI skin, improving appearance and pain without pigment changes.
Are other drugs used with LADD?
Yes, they're exploring it with 5-FU, sometimes combined with TAC. Even botulinum toxin A has been tried with LADD for hypertrophic scars, though it's hard to tease out if the laser itself contributed more in that case.
It really seems like combinations and these novel delivery methods like LADD are pushing things forward.
Definitely. It allows for more targeted and potentially more effective treatment with potentially fewer systemic side effects.
Beyond these combinations, what about totally new emerging therapies? What's on the horizon?
There's some really interesting stuff being investigated. Pharmacologically, drugs that are already used for other conditions are being explored. Things like ACE inhibitors.
Like blood pressure medication.
Exactly. They might reduce fibroblast activity and collagen production. Topical captopril showed some early promise in reducing scar height and redness. There are also calcineurin inhibitors, imidazoquinolines like imiquimod cream.
Imiquimod, isn't that used for warts and some skin cancers?
It is. Post-surgery, it might help prevent keloid recurrence, especially on the ears, but it can cause irritation and hyperpigmentation itself. Tamoxifen, usually used in breast cancer, has also shown some effect in small studies when injected.
Lots of possibilities, but needing more proof.
Absolutely. Most of these need much larger clinical trials to really establish their place.
Okay, what about non-drug emerging approaches, physical or biological therapies?
On the physical side, there's some research on electrical stimulation. A system called Fenzian was mentioned, showing reduced pain, itching, and scar scores. It might work by affecting collagen and being toxic to keloid fibroblasts. Seems safe and easy to use.
And biologicals.
Platelet-rich plasma, PRP, is getting attention. Injecting PRP along with TAC seems to improve keloid volume, color, and hardness more than TAC alone. It might also help reduce recurrence after surgery combined with radiation.
PRP comes from your own blood, right?
Correct. And then there's lab research, very early stage, looking at things like specially modified hydrogels that could inhibit keloid cells, maybe for future injection therapies, potentially with stem cells. But that's still quite far off from clinical practice.
Fascinating. It seems the future is really about targeting the underlying biology more precisely.
That's the direction highlighted in the Clinical Cosmetic and Investigational Dermatology article, too. Moving towards targeted therapies, small molecules, biologics that interfere directly with keloid formation at the molecular level.
Like what specifically?
Focusing on things like regulating those fibroblast cells, controlling collagen synthesis, maybe targeting specific signaling pathways like PI3 ACT mTOR, or cytokines involved in inflammation like TGF-beta1, IL-6, TNF-alpha.
Wow, really getting specific.
Yeah. Even exploring epigenetic modifiers, drugs that change how genes are expressed without altering the DNA sequence itself, or anti-angiogenic drugs to cut off the scar's blood supply.
And gene editing. CRISPR was mentioned.
That's on the horizon, too. Offers potential for incredible precision in targeting genetic factors, but obviously raises significant safety and ethical questions that need careful consideration.
And importantly, they also mentioned the psychosocial side.
Crucial. Providing support and education for patients dealing with these often distressing scars is a key part of a holistic approach.
It's clearly a dynamic field. Now, switching gears slightly, prevention. For someone prone to keloids, what's the advice from the AAD in medicine then?
The number one piece of advice is avoidance, if possible. If you have a history of keloids, avoiding elective cosmetic surgeries or procedures like piercings is really the best prevention.
Because any trauma can trigger one.
Any trauma. And if you do get a wound, meticulous care is important, especially protecting it from the sun. Shade, bandages, UPF clothing.
UPF.
Ultraviolet protection factor for clothing. And once the skin has healed over, using a good broad-spectrum, water-resistant sunscreen, SPF 30 or higher, is vital. Sun exposure can worsen scarring and pigmentation.
Makes sense. What about home remedies? People always ask about those. Vitamin E onion extract.
The sources are pretty clear. Unfortunately, there are no proven effective home remedies for true keloids or hypertrophic scars. They just don't work. Diagnosis and treatment really need a professional.
So seeing a dermatologist is key.
Even another doctor experienced in treating them, yes. They can diagnose it usually just by looking at it.
When treatment is pursued, what are realistic goals? Can they be completely removed?
The goals often depend on symptoms. Is it itchy, painful? And location, is it somewhere very visible? While treatments can significantly improve the appearance, making scars flatter, softer, less red, it's rare for the skin to look completely normal afterwards. Usually, there will still be some mark or difference in texture or color compared to the surrounding skin.
So managing expectations is important.
Very important. And we should also reiterate that surgery alone for keloids is risky due to high recurrence rates, sometimes reported as high as 45 to 100%.
Wow, that high.
Yeah. That's why it's almost always combined with other things. Steroid injections right after, pressure therapy, sometimes even low-dose superficial radiation therapy to try and stop it from coming back.
It's really striking how these treatments aim to help, but can also introduce other issues, like the pigment changes we discussed, especially for skin of color.
It absolutely underscores the need for that careful, individualized approach and a thorough discussion between the patient and the doctor about risks and benefits.
Okay, let's try and synthesize this. It's clearly a complex picture for managing hypertrophic and keloid scars non-surgically.
Definitely. Corticosteroids are still foundational, sort of the starting point.
Right. But then you have options like blomycin, various lasers, NDYAG, PDL, fractional ablative lasers, each with its own profile of effectiveness and, importantly, potential side effects, like those pigment changes.
And that risk profile really shifts depending on skin type, highlighting why a tailored plan is so crucial.
And we're seeing a definite trend towards combining therapies injections with lasers, LADD, silicone, pressure, trying to hit the scar from multiple angles.
Plus, there's this whole wave of emerging therapies, new drugs being repurposed, biologicals like PRP, even physical methods like electrical stimulation offering hope for more targeted and effective solutions down the line.
So where this really gets interesting, I think, is the clear message that there's no single magic bullet.
Absolutely not. What works for one person might not work for another. Your specific skin type, the age and location of the scar, maybe even your genetics, these all likely play a role.
And the science is digging deeper into why these scars form, trying to find those specific molecular targets.
Right. Aiming for therapies that can interrupt the actual scar forming process, whether it's modulating fibroblasts, controlling collagen, targeting specific genes or pathways. The potential for things like gene editing or new biologics is, well, it's quite exciting, though still developing.
So pulling this all together, what's the main takeaway for someone listening who's dealing with these scars, especially if they have skin of color?
I think the most critical point is finding a dermatologist or another physician who really understands these nuances. Someone experienced in treating scars in diverse skin types.
Because this deep dive shows it's not simple. A personalized plan, often involving multiple types of treatment, a multimodal approach seems most likely to yield the best results.
Exactly. And keep informed because this field is moving quickly. New research is coming out all the time.
Okay, finally, let's leave our listeners with something to think about. A provocative thought.
All right. Given that we know inflammation is so central to keloid formation, how might a better understanding of your own individual inflammatory profile, maybe through genetics or other markers, how might that open up entirely new ways to think about prevention or treatment? Ways that go beyond just the topical or injectable treatments we mainly use today.